Thank you, Mr. Chair. I would also like to thank the Green Crescent Society of Turkey for the kind invitation to our organization. I will start with a quick disclosure. Actually, my colleague Masar Hussein, who was the health focal point at our organization, was supposed to represent the organization in this meeting, but because of a last-minute change, I'm now trying to substitute for him. In fact, many issues have been discussed, and there is maybe not much left to say, but nevertheless, there is still an opportunity for taking one step back and looking from a broader perspective to a broader region, like OIC. After all these country cases and successful stories, OIC is a 57-member country organization, intergovernmental organization, which is known as the second largest after the United Nations. And the CESRIC, on the other hand, is a subsidiary organ of the organization. And CESRIC is where I also come from. I'm part of the Economic and Social Research team at CESRIC. And CESRIC is the main research, training, and statistics organization of the Organization of Islamic Cooperation. And when we talk about the OIC is a group of countries with a collective share of 10% in the world GDP, and they also account for 1/4 of the world population. Okay, just a quick summary. During my presentation, I will talk about first the drug prevalence in OIC countries. Then I will shift to our main focus, which is youth in OIC member countries, and I will look at some demographic indicators like the dismantling of population in terms of age and their educational status, and also the status of unemployment in OIC among the OIC youth. And I will also talk about the OIC youth tobacco prevalence and some control policies, and I will also touch upon the OIC youth drug abuse. And then I will, of course, talk about some recent initiatives of CESRIC, and I will conclude with some final remarks. In this very first slide, I take a quick look at the prevalence of some of the most common drugs in OIC member countries with available data, of course, and in comparison to other major country groups. We have opioids and opiates and cannabis. In terms of the prevalence of opioids and opiates, among those aged 15 to 64, the prevalence is around 0.6% in OIC countries, with an estimated 5 to 6 and 5 to 7 million users, respectively, for the latter two drugs. The cannabis, on the other hand, is used on average by more than 4% of the OIC population, which is quite striking, and where the estimates on the total number of users stand around 25 to 40 million. And at the bottom graph, you see the drug-related mortality in OIC member countries with reported data, and almost if I give some examples, for example, in Kazakhstan, in 2008, over 100 people died because of drug abuse. And in Iran in 2010, 69 people. And in Kyrgyzstan in 2010, 36 people. Almost all of these countries, on the other hand, they reported the opioids, which are the synthetic drugs, as the primary cause of death, which is also quite striking. Now let's go back to our main focus, youth in OIC member countries and substance abuse among those young people. In fact, OIC has a very young population, which offers in turn a huge potential, economic and social-wise. I can say more than 50%, 53.1% of the population in OIC countries, OIC member countries, is between 0 and 24. And this is much higher than other country groups by international country group comparison. And having this young population as a large portion of your population, overall population doesn't mean everything is in the pink. So you should take care of this population as well. It's a huge potential, but at the same time, it's a huge responsibility. The responsibility of course, taking care of the youth with appropriate policies and programs. And of course, this is not only the problem of the OIC countries, 57 member countries, it's a global problem because its repercussions, possible repercussions on the broader economy and the world at large is apparent. And by taking care of the population, this young population, we first mean a good education, particularly at primary and secondary levels. And some recent studies found that the use of, for example, marijuana and other illicit drugs are quite associated with a decreased likelihood of continuous school enrollment. These two graphs in this regard show enrollment rates in primary and secondary schools in OIC member countries. And if you focus on the net enrollment rate, which is the total size of population, for example, for primary school net enrollment rate, it is the population of, primary school aged young people to the overall population of those specific age group. So if you look at the NERs, which are the net enrollment rates, you see that almost 20% of primary school age children and 50% of the secondary school age children, they are absent from schools. And I discussed some possible adverse effects. These are lack of school-based awareness building for substance abuse, and difficulty of employment of an integrated drug control policy, and the challenge of coordinating action among schools, parents, health professionals, and public officials. A similar argument is also true for the school repetition rates in OIC countries. So even the children are enrolled in schools, it is more likely that they will fail and they will repeat, and this will increase the likelihood of dropouts and exposure to substance abuse. In this slide, we see, according to the ILO, International Labour Organization estimates, the average percentage of youth unemployment in different country groups. And in 2010, we see some 17% of young people in OIC countries did not have a job, and which was again relatively high, despite some improvement in time, when compared to other international country groups. And even in some countries such as Mauritania and Guyana, Gabon, Egypt, youth employment reached about 1/4 of the youth population. And again, unemployment affects the exposure to substance abuse through a number of well-known channels, which are, for example, increase in stress factors and resort to alcohol and drugs to mitigate possible negative effects, and therefore a greater likelihood of addictive use of drugs. And this graph shows the prevalence of tobacco use in OIC member countries, and we see that OIC countries exhibit globally comparable, in fact, youth tobacco prevalence levels when compared to other developing and developed countries. For example, in OIC countries, 15% of youth, the overall youth population, use tobacco. And in other developing and developed countries, a similar picture is valid. But yet there is a significant amount of disparity between male and female youth tobacco prevalence in OIC member countries, as male youths are twice more likely to use tobacco when compared to their female counterparts. In fact, OIC member countries made significant strides to curb the use of tobacco and its adverse repercussions on the member countries. The most prominent initiative in terms of curbing the tobacco use globally, in a global setting, was the WHO FCTC framework of Convention for Tobacco Control, and 54 member countries out of 57 actually signed this agreement, except for Indonesia, Palestine, and Somalia. And 35 out of 41 countries, OIC countries, they reported having a comprehensive legislation to control tobacco use. And 47 out of 56 member countries with available data, they reported the existence of national objectives on tobacco control. In fact, the statistical capacity on drug use among youth is unfortunately very scarce and limited. Some capacity-related indicators we extracted from WHO Atlas on drug use indicate particularly low statistical capacity in regions where OIC countries are mostly located. For instance, on the top graph, you see the percentage of countries by region who reported having a national survey on youth alcohol and drug use. In Africa, East Mediterranean, and Southeast Asia regions, you see a significant portion of the countries, they report a lack of such surveys, and most of the OIC countries, in fact, they reside in these regions, 3 regions. And a similar argument can be made for also the treatment data collection system. And again, in Africa, East Mediterranean and Southeast Asia regions, there is a significant gap in terms of statistical capacity. As we said, the statistical data for youth drug use is quite limited, but still we made some effort to extract some data for some member countries, and we have here the youth drug prevalence for cannabis and opium and heroin. And as you see in Egypt, for example, the use of cannabis is quite prevalent with 19% almost, and it's followed by Latin American member countries like Suriname, Guyana, and then North African countries like Morocco and GCC, Lebanon, and from Europe, Albania. And of course, this compares favorably to some of the other developed and developing countries like Canada, Czech Republic, Spain, and USA, and Poland, Germany, where the prevalence of cannabis use is quite significant. And when you look at the opium prevalence in OIC countries, again, Albania, Turkey, Kyrgyzstan, Guyana, Suriname, Indonesia, they stand out. But again, this compares favorably to some other countries like Andorra, South Africa, Chile, Bulgaria, Canada, and Portugal. As for cocaine, again, we have some 5 member countries with available data. Albania 2.8, Turkey 1.6, Guyana 1.2, Suriname 1.2, and Indonesia quite low number, 0.2% cocaine use among youth. And in Chile, for example, 24% of youth, they use cocaine as compared to Canada, where the prevalence is 7.2%, and USA 5.5%, and so on. And this is similarly for amphetamines, which are known shortly as ATS, sorry. Oops. And then we have drug control policies. This map shows the available drug control policies worldwide. And as you see on the map, the majority of the OIC countries in sub-Saharan Africa is deprived of a national policy for substance use. And those in Middle East and Central Asia, they have either integrated or separated policies on drug and alcohol, or as in the case of Iran and Kazakhstan, they have a national policy on only on drugs. And as for the most commonly used treatment setting in OIC member countries, we see a very limited number of countries, most of these in Middle East and Central Asia, including Turkey, and offers a special care program for youth drug users. And in terms of physical infrastructure, we depict in this graph the available number of hospital beds for specifically for drug users. And yesterday we were discussing with a colleague from Turkey, I think he was from TÜBİM, and he said we have almost 400 beds in total in Turkey for drug users. And this was a confirmation of, in fact, this figure. And I checked the Turkish data, and it was validated, so it was around 4,000 or 5,000 beds, which is as low as 6 or 7 beds per 100,000 drug users. And if you take the OIC average, you come up with a figure like 3.3 beds per 100,000 population. And in other developing countries, it's 4.4, and in developed countries, it's almost 13 beds, and in the world average is 4.8. So this also signifies and indicates the significant lack of also the set aside the technical infrastructure and availability of treatment services. Also the lack of physical infrastructure. So this is also another significant challenge for OIC member countries. So let me also talk a little bit about the CESRIC initiatives, which can be related directly or indirectly to drug use and drug use control in OIC countries. The first one is OIC Strategic Health Program of Action, which was prepared by CESRIC for the period 2014 and 2023. This is a framework of cooperation among OIC member countries, relevant OIC institutions, international organizations in the domain of health. And this strategy aims to strengthen healthcare delivery system and improve health situation in OIC member countries, especially by facilitating and promoting inter-OIC transfer of knowledge and expertise. And CESRIC, our team was the lead coordinator for the preparation of OIC Strategic Health Program of Action and its implementation plan. And this strategic plan was adopted in the last meetings of the OIC health ministers, which was held in Jakarta, Indonesia, in 2013, last year. And as I said, this is now, the implementation phase is set in motion and is continuing now. How it relates to drug control, drug abuse issues, we have one thematic area. In fact, we have 6 thematic areas identified under this plan of action. And one of these areas is, of course, the disease prevention and control. And no need to discuss the interplay between drug use and its impact on communicable diseases like HIV, hepatitis, and also non-communicable diseases like respiratory problems and the cancers and other type of diseases. So we diverted our efforts specifically to this area, and we established one working group working in this area, and one country is leading all the efforts under this area. So it's up and running now. I think I will skip this one, and I will come to OIC-VET. The OIC-VET program is the Vocational Education and Training Program for OIC member countries. It was launched by the Honorable then President, Mr. Abdullah Gül. Under the OIC-VET APEX program, we have about 40 sub-programs, and I listed some of the related programs in this slide. Ibn Sina program for health capacity building aims to organize some short-term health training programs to improve the health service delivery and practices in OIC member countries. And we have tobacco-free OIC initiative, which I should be a drug-free OIC initiative from now on, maybe. And we aim to foster an OIC-wide coordinated approach to curb and control the spread of tobacco epidemic in OIC member countries through training and capacity building programs. And we also try to facilitate the development and implementation of sustainable national tobacco control strategies. And lastly, we have skill development for youth employment. We contribute to the solution of the unemployment problem through improving necessary skills for the current labor markets, offer an experience and a best practice sharing platform to develop effective models to fight against youth unemployment. And TQS, some of you might already know about this initiative. This initiative was launched by WHO and CDC, which is the Center for Disease Control, US Center for Disease Control. And these two institutes, they set together to design the tobacco questions for surveys, and this specific set of questions, they can be used as a standalone module in national surveys, and it can be used to measure the tobacco use and key tobacco control measures defined by the WHO FCTC. And I think 2 months ago we sat together with the CDC in Atlanta, and we reached an agreement to implement the TQS surveys in 15 high priority OIC member countries and some other 4 relatively low priority OIC member countries. And some final remarks. I think there is a consensus on the fact that a drug is a drag on development, but its economic and social burden, for example, the years of healthy life lost due to health disorder, is almost impossible to quantify, given the existing lack of statistical capacity. So OIC countries, in a nutshell, they have a huge youth potential vis-a-vis huge risks ahead. So this means the less educated and less busy youth means more vulnerability to potential drug abuse cases. And it was raised by many colleagues, a good number of colleagues raised this issue throughout the forum. Of course, religion has a role to play. I don't think there is any religion which encourages or promotes the use of drugs. And we are entrusted with our body, and we should return it in best form. But as long as the performance of religious rituals are not seen as a way of moral compensation, I think the moral compensation is a key word here. If you don't teach people not to use the religious rituals as an offsetting or justification tool for their sins committed, through using drugs or other harmful substances, then this can turn into a moral compensation tool, which is very dangerous. And last, not the least, I should maybe once again emphasize the role of capacity building as a technical modality for sharing knowledge, experience, and expertise. And the institutions like CESRIC are ready to take their part. I think this concludes my presentation, and I thank you for your patience.